When a patient comes to you with a pain from loin to groin, the patient shows the pain by using his fingers, putting at the renal angle, whereas the thumb shows the umbilicus. This is the typical presentation of renal pain. The pain comes down along the pathway of the ureter and comes to the upper part of the thigh along the groin, which goes to the tip of the penis, base of the scrotum, and in case of a female, up to labia majora. Right? Now, how to show the pain region, that is ask the patient to lie down supine, put your fingers on the renal angle. What is the renal angle? What is the renal angle? It is the lower border of 12th rib with outer border of erector spinae muscle. Renal angle is, this is outer border of erector spinae muscle with the lower border of 12th rib. So you are going to put your fingers at that area, and one hand will be in front, and you will be able to push the kidney towards the anterior aspect. This is called sign of balloting. Kidney is a ballotable organ. So you will be able to show it by balloting. Right? Next, you are going to understand what is the nature of the pain, whether it is dull aching or it is colicky. Alright? If it is spasmodic pain with intermittent relaxation, this is a colicky pain. Alright? This is usually severe, and the patient usually tosses and turns on the bed unless it is relieved. This renal colicky pain may be due to stone or spasm due to blood clots, and the renal pain of the kidney is due to distension of its capsule. Renal pain is due to distension of its capsule. You have to investigate whether the patient is having, what is this? Remember, when you are asked any embryological questions, there are some typical terms like blastema, trumpetization, astrophy. If you do not give these words and write ABCD, it won't be an embryological answer. You have to put some specific words to describe this embryological event. Understood? That is a metanephric cap, ureteric bud, nephrogenic cord, splitting of nephrogenic cord, division and subdivisions of this mesonephric duct, that is neck to ureteric bud. Then after the splitting, there is formation of the first order, that is the major calyx, and second, third, fourth order gives rise to minor calyx. And after this, up to 13th stage, this will give rise to formation of collecting tubules. And by the sides of this calyceal system, there is appearance of bilaminar cell cluster. This is embryology, bilaminar cell cluster, from which renal vesicles develop, and the renal vesicles grows, giving rise to the tubular system, that is the Bowman's capsule with glomerulus, then the pre-tubules of before the loops of Henle, then the tubules after the loops of Henle, and up to this the duct doesn't connect with the collecting tubules. There remains a septum. When the septum dissolves, then the excretory system and the collecting system get united, and starting from 9 months, kidney starts functioning. Starting from 9th week, kidney starts functioning. You have to write these words. These words describe an embryological answer. Anyway, here you can see that this figure shows the ascent of kidney from the pelvic region, it was where it was supplied by the medial sacral artery. As the ureteric bud grows upwards, this is stretched and elongated due to the uncurling of the vertebral flexion. It was vertebral flexion, so there has been no elongation of ureteric bud. As it is uncurled, there is much space for the ureteric bud to lengthen. So from the pelvic part, it comes to the right iliac fossa, then along the posterior abdominal wall up to the subdiaphragmatic area, meeting with the suprarenal gland. Can you see it? And thereby, when you are asked the arterial supply of ureter, describe the arterial supply of ureter, you have to describe all these arteries, that is the median sacral artery, common and internal iliac artery, the gonadal artery, the inferior vesical artery, peritoneal arteries, and renal arteries coming from the suprarenal artery. All right, all these arteries you have to mention when you are going to describe the ureter. If a question comes on ureter, you have to write all these supplies. Now the next figure shows there is a displaced kidney. The next figure shows there is a fused kidney with displaced ureter. The kidney of the other side has come to this side, and the above one is the normal for this side and lower one is the displaced kidney. Right. Next you see a discoid kidney. Next you see the discoid kidney. Two kidneys are fused within a circular space, and there is the regular ureters from them on the back. Next comes the horseshoe-shaped kidney. Horseshoe-shaped kidney, there is an isthmic tissue. There is an isthmic nephrogenic tissue in between the lower pole of both the kidney. This is important. Until and unless you mention isthmus, other description of a horseshoe kidney is useless. So you have to mention that is there is an isthmic tissue between the lower pole of the two kidneys, and the ascent of this kidney and the ureters are behind, blood vessels are also behind, and there is an inferior mesenteric artery which prevents the ascent of such a jointed kidney. There is inferior mesenteric artery that prevents the ascent of such a joint kidney. Next comes an anomaly where you can see single kidney with double ureter. In the next stage you can see single kidney with double ureter. Both the ureter can open into the bladder separately, or they may directly communicate with the preprostatic urethra. They may communicate with the bladder separately, or both of them in a united way can join with the preprostatic urethra. Next comes the floating kidney. Next comes the floating kidney, where there is a lateral fold of peritoneum from the lateral wall of the pelvis. Right? It makes the kidney floating, and that there is twisting of the blood vessels, both the ureter as well as the blood vessels. This twisting causes sudden severe pain and severe pain with suppression of urine. This is called Diethel's crisis. Now, by number, kidney can be classified as number 1 agenesis and multiple kidney. In case of agenesis, in case of any planned renal surgery, you have to investigate whether the other kidney is all right or not. whether the other kidney is all right or not. Otherwise, you have to defer and change the plan if the other kidney is not normal. And multiple kidney, as you see, as it is a lobulated organ, there can be formation of multiple kidney tissues within the posterior abdominal, in the posterior abdominal wall. Thereafter comes the fused kidney by shape, horseshoe-shaped kidney, discoid kidney, size, shape. After that comes the blood vessels, abnormal renal artery. There could be accessory intersegmental artery for the kidney, which supplies the lower pole, which supplies usually the lower pole of kidney, coming directly from the abdominal aorta. That is important. So, the segmental artery that is supplying the lower pole, and it might press on the ureter, causing hydronephrosis. All right. Next, what are there? One or two things you may write, you may write or may not write. And the last thing is the polycystic kidney. Right? Last thing is the polycystic kidney. So, as I have said, with the splitting of the ureteric part and the presence of metanephric blastema from the nephrogenic cord tissue, there is formation of cell clusters by the side, where from there is renal vesicles. When the renal vesicles elongate, there is proximal convoluted tube, formation of proximal convoluted tubule, the Henle loop, and distal convoluted tubule, which connects to the collecting duct after the disappearance of the septum in between them. In polycystic kidney, this is the pathology. That is, the renal tubules doesn't get communicated with the collecting portion, that is with the duct of Bellini. These are separated. So there is formation of cystic degeneration of this tubule. And sometimes the renal vesicle also give rise to the cystic degeneration. This is two forms of polycystic kidney. One is acquired and adult, and another is congenital. Right? Another thing is that when a patient comes to you with hematuria, the other important renal symptoms are the hematuria. All right. The causes of hematuria are mostly due to cystitis, papillary tumor of the bladder, and the bladder stone. All these can cause hematuria. Hematuria maybe at the beginning, at the end, and in between. You have to diagnose what is the time of hematuria and what is the reason and where from the bleeding is coming. Next renal symptom is suppression of urine, that is oliguria or anuria. Anuria is less than 100 ml of urine per day, and oliguria is less than 400 to 500 ml of urine per day. In case of infant, it is 1 ml per kg per day. 1 ml per kg per day. This is for infant. And for the children, this is 0.5 ml per kg per day. Now, to distinguish, you can do X-ray, IVP, intravenous pyelogram, renal DTPA scan, that is scintigraphy, ultrasonography, CT scan, and MRI, together with estimation of some blood levels, that is the acid phosphatase, alkaline phosphatase, In which condition acid phosphatase increases? In which condition acid phosphatase increases and in which condition alkaline phosphatase increases? किसे बढ़े acid phosphatase and alkaline phosphatase? Acid phosphatase usually increases in prostatic pathology and alkaline phosphatase increases in osteologic pathology, in bone pathology, right? And there is another thing, that is the PSA, prostate specific antigen. It is also done in case of urinary case, and 4 nanomilligram per ml. The normal range is 4 nanomilligram per ml. This is the PSA. Ask any adult person, middle-aged person, have you done your PSA? If there is much frequency and obstruction to initiation of urine, there must be benign prostatic hypertrophy. If there is delay in initiation of micturition and frequency of micturition, this is the symptom of benign prostatic hypertrophy. All right. So, hematuria, frequency, suppression of urine. Another thing is retention of urine. All right. There is another thing, that is the retention of urine. Retention of urine is also maybe acute or chronic. In acute retention of urine, the patient comes to you with burning pain in the suprapubic region. You have to percuss the area whether the bladder is full or not. You have to percuss the area, infraumbilical region, to see whether the bladder is full or empty. If it is full, then you will first try catheterization, simple rubber catheterization to relieve. And if it is failed, then you will try to put a Foley's catheterization. If the bladder is relieved, all right. If the bladder is not relieved, then you have to do a suprapubic cystostomy. You have to do a suprapubic cystostomy. So first, simple rubber catheter. Second, Foley's catheter. Last, if it fails, then you have to do a suprapubic cystostomy. Before doing suprapubic cystostomy, you have to be sure that this is bladder. Otherwise, you cannot cut the tissue and enter into the space of Regias, that is where the bladder is situated. So, suppression of urine, retention of urine, hematuria, renal pain, and there is renal mass. There is renal mass, that is the renal lump, that you have to find and differentiate from other organs by balloting the kidney from the bag. As the pain comes from the renal angle towards the umbilicus and towards the groin, it is called loin to groin pain. It is called loin to groin pain. In urethritis, cystitis, and papilloma of the bladder, there is hematuria. And you have to find which region of urethra is affected. Which region of urethra is affected. Can you read the labeling? Labeling to পড়া যাচ্ছে? Labeling to পড়া যাচ্ছে? Other people? Can you read the labeling? It is seen. So, find the diagnosis and progression of the disease, condition and progression of the disease. We do blood test, as I have mentioned, acid phosphatase, alkaline phosphatase, the blood count, as well as the prostate specific antigen. Then we do straight X-ray abdomen and lateral view that differentiates it from the renal stone and the gallbladder stone, right? Next we do intravenous pyelography. If intravenous pyelography gives the stretching of the calyceal system, then it is all right, giving rise to the spider leg deformities. If it is not found, and there is smooth stretching of the calyceal system, that is, the kidney is not properly filled with the dye. So we may do retrograde pyelography or voiding or micturating pyelography. Understood? There may be pathology, that is the posterior urethral valve and pinhole meatus, that can cause acute retention of urine, and you have to do cystoscopy and sometimes retrograde cystoscopy, cystourethrogram and the retrograde cystourethrogram. In case of newborn baby and kids, there is formation of posterior urethral valve with hydronephrosis, for which cystoscopy and cystourethrogram is indicated. All right. And in hydronephrosis, you need to operate through number one, Anderson-Hines operation, and another is you can put the lower end of the ureter into large guard. You can put lower end of the ureter, which is anomalous, can put into the large guard. So Anderson-Hines operation and the diversion of urine through the large guard. Anderson-Hines operation and diversion of urine through the guard. All right. Remember this thing and go on reading embryology. As I have mentioned, you have to mention some typical terms while you describe embryology. So, fate of the mesonephric duct, ascent of kidney, directly polycystic kidney, or as anomalies of kidney, development of kidney. All these comes as a question. Fate of mesonephric duct, ascent of kidney, and the arteries that are supplying to developing kidney. কোন আর্টারি সাপ্লাই করছে, ঠিক আছে, ডিউরিং ইটস অ্যাসেন্ট, কোথায় আছে, কাকে সাপ্লাই করছে, পেলভিসে আছে, মিডিয়ান স্যাক্রাল আর্টারি, অলরাইট, রাইট ইলিয়াক ফোসাতে আছে, কমন ইলিয়াক অ্যান্ড ইন্টারনাল ইলিয়াক আর্টারি. অ্যাবভ দ্যাট there will be inferior vesical, renal and gonadal and renal artery, and in case of female there will be uterine and vaginal artery. All right.